Okay, so Chairman, ladies and gentlemen, it's a great honor for me to be here and to give this short lecture. I would like to tell a few words about prostate cancer meds treatment. So, SBRT of prostate cancer meds. The first issue is definition. What does it mean, the oligomeds? There is a broad selection of different definitions which you can find in the net, but I like mostly this definition of Samuel Hellman. So oligomeds are meds which appeared in very early stage of disease and they have no potential to very aggressive growth. So we can deal with them something like radical treatment. We should differentiate between oligomeds and oligorecurrence. It's a different situation. It's a situation in which we control the primary site, so the prostate in this case, and we found during the follow-up some meds. From the practical point of view, we have two situations, lymph node meds and bone meds, thinking about the prostate, of course. So let's start with lymph nodes. The number of publications which you can find, it's not very large, but we have something. All these publications have some common features. So the first, not very large number of patients included in this series. The second one, quite large variety of delivery doses, total doses as well as a fractional. Very good local control. Nearly excellent local control and not very large toxicity. So it seems to be very good and effective treatment, but it's not very common. So what was going on with this treatment? I don't want to give the lecture as a state of art. I would like to stand on my personal experiences in this field. So we did something in this field. I published with my co-workers in Technology for Cancer Research and Treatment 2 years ago, very short series of 31 meds in lymph nodes treated with a cyber. I will talk only about the CyberKnife treatment. So we delivered those for GTV plus margin. There was some discussion about margins, and I absolutely agree when we talk about intracranial location, sometimes we can skip the margin. Yeah, it's the stable situation. And when we treat a moving target, I'm thinking about the breathing mobility, sometimes it's more than 2 centimeters, and we must use the synchrony, we must take into account some margin. So this is the first reason of that, and second reason for the margin is subjectivity of imaging assessment. So in the simpler words, I do not believe in very high precision of CyberKnife, and secondly, I do not believe in my contouring. We did it using a fiducial tracking and usually synchrony, as well as spine tracking. So what we did? We used the different scheme of fractionation, and now I think only this market in red could be considered as a radical ones. What we found? Excellent local control. You see after 1 year is 100%, and quite large and fast decline of PSA concentration. But the series wasn't very large, so in this year we made some update. We included 51 lymph nodes, but patients who had only up to 3 metastatic lymph nodes. So it's selected group. As you see, features of this group are typical, vast majority oligorecurrence, there is some shifts, or sorry for that. And the majority from the high-risk patients, and also the vast majority treated before with radio. So delivered fractional as well as total and biological doses were very different. The GTV was more or less about 1 cubic centimeters and up to 6 centimeters PTV. Majority got ADT during this treatment. The overall survival in this group of patients was very good. So you see 1, 2 years and 3 years overall survival, 92, 74, and 74%. So it's excellent for dissemination. The progression-free survival much worse, of course, because some patients developed mets in other places, lymph node or bone mets, and there was some group with biochemical progression. So it's natural history of neoplastic disease. We found also that the progression-free survival and the biochemical progression-free survival have some impact on overall survival. It's absolutely clear. And the progression-free survival was better in the subgroup of patients with oligomets and worse in the subgroup with oligorecurrences. You remember the definition. The worst progression-free survival was for larger tumors, for progression of PSA during follow-up, a modification of ADT, and the castrate resistance. But I think all three these factors are connected. And similar like the last one is connected to these three. So what can we conclude, if we can, on the basis of obtained results? I don't think that these results permit us to form the conclusion that it's very good treatment. I think that we can say that it seems to be effective treatment in terms of local results, so good local control, quite good PSA decline. And what do we know that it's better, it's easier to treat the patients with oligomets than with oligorecurrences. But that's all. I would be very careful to form some robust conclusion on the basis of these results. What do we do now with oligomets? Still, we treat these patients. We deliver 3 times 15 gray, basically. In some cases of high-risk patients where we irradiate the nodal fields, so we do some reduction if the node is located within these 44 gray fields. Similarly, in the case of oligorecurrences, it's 3 times 15 grays. If some dose was delivered earlier, we must reduce the delivered dose, and sometimes because of proximity organ at risk and time factor and so on, so on. We do it like previously, mainly with fiducials and GTV plus margin. We treat up to 3 lesions. If more, we skip, and this is a palliation only. Bone mets, the next part. I think it's even more complex problem. Literature is similar. So, not very large number of publication, not very large series, different fractionation, not very long follow-up, very good local results, good PSA decline, and not very high toxicity. Also, we published something in this field, 71 oligomets bone. Of course, oligomets, the treatment, CLR, GTV plus some margin, spine tracking, 6D skull, or fiducial tracking, dependently on the situation. Here you see some met in ribs, so it was, of course, the fiducial and synchrony, and the spine. The patient had, still have, I don't know, the met in the vertebra. When we look at the patients, the typical group, so in good performance status, majority intermediate and high Gleason score, vast majority treated with radio, and the total dose quite large range. I'm thinking, and I'm talking about the previous, of course, treatment. When we look at the mets, different number of the mets, up to 5 mets. All the mets were found using different imaging. Now we use only PET for this purposes, fluorocholine or PSMA, mostly PSMA because it's easier. Location mainly in the spine, so it's typical. quite large time between diagnosis and primary diagnosis of METs, and quite range wide range of PSA. So probably it was a mistake, this qualification, it was dissemination. As you see, we used also wide selection of fractionation schedules, but only the 3 last ones now from this actual point of view could be considered as a radical. Toxicity, nothing about toxicity, it's still PSA decrease, so quite fast and quite large. Of course, we should be conscious that some ADT was used also in this group, as you saw previously. The local control, very good. When we think about the bone mets, so 97% and 70% after 1 and 2 years of follow-up. The pain relief, excellent, but we can expect such results. So nearly 100% in the last control is 92% of pain relief, and the vast majority is complete pain relief. Toxicity not very high, so patient had 2 fractures, but we are not absolutely convinced if these fractures were due to radio or due to disease itself. So we don't have a possibility to guess and to differentiate these 2 situations. What we found that the better prognosis in terms of overall survival is in the subgroup of patients having very low PSA, so it's clear. And the concentration of PSA during the diagnosis of METs was very important and was an important prognostic factor. It was higher than 20 nanogram. The prognosis was much worse. So still PSA and PSA, and the same situation you have when you irradiate the primary and the radical treatment. What can we conclude? So similarly like previously, it seems to be good treatment, but we aren't sure if really it's very effective treatment. So we know that PSA is high, so results are worse, but it's nothing new really. So what we did, we constructed some clinical trial comparing common treatments, so once 8 gray, I think it's the standard in whole Europe for bone mets, 2, 3 times 15. So what we did with Cyber, we want to include 100 patients and compare results. So the accrual is not very fast. There is quite large resistance of patients and the doctors because all of them want to be treated with Cyber or some other radiosurgery. So now we have 12, but well, I'm optimistic. I think that we'll have this 100 and we can compare. These materials were not very large, so it's very difficult to form some conclusion. So what we did finally in September, and it was presented on Astro in last week, we found all patients who had up to 3 mets, lymph nodes as well as bone mets, and we recalculate our results, we checked them. So it was a group of 84 patients, so it was about 150 mets, a quite large number. As you see, here you see the percentages of mets 1, 2, and 3 mets. As previously, a majority of patients from high-risk group, so it's clear, and radio as well as ADT previously used in majority of cases, so the vast majority were oligorecurrences. The time from initial diagnosis to the mets quite large. Here you see some median and different delivered still total and biological doses, ADT used in majority of cases, and GTV and PTV similar like in previous slide, so about 1 cubic centimeters, and here more than 6 for PTV. What we found in this group of patients? When we look at the overall survival, is very good, surprisingly good, I think. And the 1, 2, and 4 years overall survival is 94, 82, and 78%. So 10 patients died in this time. And the impact on overall survival had progression, again, progression-free survival and biochemical progression-free survival. What is also clear, and we can find it in every article. When we look at local control, the situation is also okay in the first period up to 3 years, because it's 92, 91, and 84%. But when we look at this longer time, it's not so nice. So the positive impact on local control had the diameter, so it's clear it's better for us to treat small tumors, a smaller number of mets, and presence, maybe absence of bone mets. Yeah, it's better. So progression-free survival was much worse, but it's typical for this group of patients because of some mets which developed themselves in other lymph nodes and bones. So 1, 2, and 3 years progression-free survival was 70, 56, and 53%. And finally, biochemical progression-free survival situation is similar. 1 to 3 years was 74, 65, and 55%. So overall survival okay, but the rest of endpoints not so good. So again, what can we conclude, if we can conclude something on the base of this data and obtain results? I'm not absolutely sure that we are allowed to form some robust conclusion. These series are not so large, and I don't know data in literature which support some statement that this kind of radiosurgery is a good treatment. What can we tell? It's not bad treatment, and I believe in the treatment personally, and still we do it. But I think that to be sure, if this treatment is effective and if it could be considered as the radical one, we should try to construct some clinical trials, and only in this case we can be absolutely convinced that we are right in our activity. Thank you very much.